Welcome back everyone to session 2. Panelists, I'll ask you to kindly mute your mics and turn off your videos. And session 2 is going to focus on the practicalities of treating obstructive sleep apnea with CPAP. Sophie, oh. And so I'm just going to start off by flagging something which will be extremely obvious to you all, and that's that we start off with lifestyle advice for all severities of obstructive sleep apnea. And it's interesting to me that when we receive referrals, people are quite comfortable to say, oh, this patient has been a smoker and they've got COPD. Somehow in our society, we feel that acknowledging obesity is taboo. And I think it's up to us to find the language in which we can discuss obesity and offer support, because patients are likely to be more receptive to advice around the time of a diagnosis. So I'm going to kick off in this session talking about treatment of mild obstructive sleep apnea. And NICE has explain to people with mild obstructive sleep apnea who have no symptoms or minimal symptoms that they can be treated with lifestyle alone. This is probably the minority of our patients because they have to have a few symptoms to earn their place in the clinic with referral. And this, in my opinion, is likely to refer to people who've come in from pre-op screening clinics, or maybe people whose partners have been concerned by pauses in their breathing. So TA139, published in 2008, was a really important bit of guidance. Up until that time, it wasn't really acknowledged that obstructive sleep apnea was a real condition with very burdensome symptoms. And it was a fantastic lever to enable centres to diagnose and treat obstructive sleep apnea. Well, what did it say? It demonstrated an extremely favourable ISA, incremental cost effectiveness ratio, for patients with moderate and severe obstructive sleep apnea to have treatment with CPAP, and that ISA came in at less than £10,000, so very favourable. What did TA139 say about mild obstructive sleep apnea? Well, the ISA crept in at just over the somewhat arbitrary ISA of £20,000, which we have said for a couple of decades is the threshold for being taken on by the NHS. And so it concluded that for mild obstructive sleep apnea, CPAP was not appropriate as the inconvenience will probably outweigh the benefits. The default was to offer lifestyle advice unless the symptoms were really severe. So for our latest review, there were 6 randomized controlled trials of mild obstructive sleep apnea informing the guidance. Now I've listed them here in chronological order, and these top 3 studies here were published. They're the ones above the red dotted line. They were published prior to 2008 with a grand total of 156 patients. They demonstrated that CPAP treatment led to an improvement in symptoms, but perhaps not sleepiness. Improvement in symptoms and cognition here with this second study, but unfortunately many patients didn't find it acceptable. And this third study showed an improvement in symptoms, but not the multiple sleep latency test or the Epworth sleepiness score. And there was a pretty good response in the placebo group as well, perhaps demonstrating how important someone who's interested in your healthcare and well-being is. So I'm delighted to say that in the intervening period, there have been a further 3 studies published. We now have a grand total of 1,003 patients on which to base our opinions. And these showed a much more favourable improvement in sleepiness and functional outcomes. We had an interesting race to the finish line. The NICE review process was going on, and in parallel, Julia Kelly and Mary Morell from the Brompton Imperial College were leading a UK multi-centre trial of patients with mild obstructive sleep apnea. It was called MERGE. And within the trial were 233 patients randomized to auto-adjusting CPAP or best supportive care. The median AHI was around 10. And I'm just going to pause and ask you to focus on this bit of data, which wasn't an outcome measure, but I think is really interesting. The average use of CPAP in this group was really excellent at around 4 hours. And I suspect this is because Julia and her team were avidly following up patients with lots of regular telephone support and median contacts of 5 over the study period of 12 weeks. And interestingly, 81% of patients wish to continue CPAP at the end of the trial. The primary outcome measure was the change in vitality using the SF-36 vitality score. And here we have rather similar scores at baseline. And after 3 months, the best supportive care group had little change, and there was an excellent improvement in the CPAP group. All well and good, but of course the patients were not blinded. So I think it's rather gratifying when you look at the various domains of the SF-36 that energy and vitality improves, but bodily pain does not, and other physical symptoms that you wouldn't expect to change with CPAP treatment. The Epworth Sleepiness Score was only a secondary outcome measure, but it improved significantly. And so what can NICE say now? Well, NICE is now able to say that for people with mild obstructive sleep apnea who are symptomatic, at the same time as lifestyle advice, offer CPAP. And it can also be offered if lifestyle advice alone has been unsuccessful or considered inappropriate. And in my book, the clock starts ticking from primary care, because I think primary care practitioners are excellent at offering lifestyle advice, rather than from the clock starting ticking from the secondary care sleep clinics. My colleagues are going to go on to talk about telemonitoring and follow-up, so I won't spend any time on this. And what's the impact of this new guidance? Well, here's a publication from Adam Benjafield at ResMed and Mary Morell at the Brompton. And it's a somewhat frightening slide. It shows a very high prevalence of obstructive sleep apnea on sleep studies. Much of this data is extrapolated from smaller studies, but it estimates that in the UK, the prevalence of moderate and severe obstructive sleep apnea is over 1.5 million. But if you include mild sleep apnea, that would be increased to 8 million, which is a somewhat frightening statistic. However, I think it's worth bearing in mind that not all these patients need to be treated, because some of them would be asymptomatic. I suspect many of our clinics are treating these people already, and we know that sleep apnea gets worse with age, so it may be that we're just delving in and capturing these people at an earlier point in their history. So that's the summary of treatment for mild sleep apnea, which I have covered already. And I would now like to hand over to Adrian Kendrick from Bristol.
Okay, so what I'm going to talk about is how to initiate and determine the pressure of the CPAP. Like pulse oximetry and respiratory polygraphy, this was, I think, a heavily discussed area. And what the recommendations state is that we offer fixed level CPAP, obviously in addition to any lifestyle changes, for people with moderate to severe OSA, but also in those patients with mild. How you set that up, the fixed pressure, will be determined by local protocols. That might be using, oddly enough, auto-adapting CPAP over 2 or 3 nights to then get an average pressure to which the patient is then fixed. The debate over whether or not it should be fixed or auto at the start and used long term was, as I say, strong. The important thing is that the information, the data that is available in terms of economic cost suggests that fixed pressure and auto, probably just purely on cost, fixed pressure is cheaper. There is some caveats to that, which I'll come to in a moment. Whatever you do locally and is agreed locally, offering CPAP is important, and they should be monitored and telemonitored for up to 12 months. We know in particular that the trial period, the initial setting up and getting the patient established on CPAP does require fairly close monitoring, and this is really where telemonitoring is of significant use. Whether or not you follow up patients after the 12-month period, I think to some extent depends on the patient. The decision here is consider, so it is not the same as offer. And I think there will be some groups of patients in whom you might want to consider offering telemonitoring beyond. I think offering telemonitoring to every single patient when you've got 9,000 or 10,000 patients to monitor may be beyond the scope of most services. Auto CPAP is in 1.6.3, and it is suggesting that you consider this as an alternative to fixed level CPAP in patients where a high pressure is needed for only certain times of the during period of sleep. So this might be positional. This might be if you happen to know that patients go out on a number of nights per week and have a few beers, and of course then they would need a higher pressure in order to control the effects of alcohol. So you might want to consider it in that group of patients. There will be some patients in whom fixed pressure is just simply not tolerable. They can't work at 12 centimeters of water continuously through the night. And in those patients, again, you might want to consider auto CPAP. It also suggests auto CPAP where telemonitoring cannot be used for technological reasons or local policy reasons. And finally, the important thing is that auto CPAP is available locally at the same or lower, I would choose the word similar cost to fixed level CPAP, and that the price is guaranteed for the length of the contract with the supplier. What the guidelines in terms of economic cost did not include, which may influence whether an auto CPAP is better than fixed pressure, is actually the amount of interaction in terms of physiology nurse time managing patients who are on fixed pressure, whereas putting them onto auto CPAP may actually reduce that. And one of the things that if you look within the guidelines into the research recommendations, research recommendation number 1 is that more work needs to be done to look at this particular area as to whether auto CPAP overall, looking at the bigger picture of interaction with the clinical teams, is actually cheaper than the use of fixed pressure. So it remains, I'm going to choose the word controversial issue. 1.64 is fairly obvious, and I think most people would consider heated humidification in patients using CPAP, whether it's mild, moderate, or severe, who are particularly having upper airway side effects and particularly nasal and mouth dryness. And also particularly with CPAP-induced rhinitis. It's completely reasonable and sensible, but not, I think, every patient needs to be set up at the start with heated humidification. Next slide, please. So this was put in because we have a little bug going around. It's called COVID-19. And throughout the document, I think in 6 different places, this is highlighted that CPAP and indeed NIV is an aerosol generating procedure. And it is hugely important that we manage the way we set up CPAP patients. Pre-COVID, we can't do that as well as we used to do. We used to bring in 7 patients into a room, set them up, put the CPAP machine on, switch it on to get them used to it. Because we now have COVID and it is and CPAP and NIV are aerosol generating processes, we need to look differently as to how we actually set up patients, whether it's remotely, whether it's in smaller groups, whether it's going back to one-to-one. That has to be discussed locally. For me, having worked on a number of groups advising on COVID and respiratory physiology over the last 18 months, there are 2 key things. We must protect our staff as much as we can by taking appropriate measures using PPE, and we must also protect all the patients that we see. And that is, for me, absolutely paramount in how we move forward in managing large numbers of patients who are going to need to be set up on CPAP. We must practice safely. And there is UK government guidance on this. There is World Health Organization guidance on this. There is CDC guidance on this. And I will finish there. Thank you.
Thank you, Adrian. So I've got the next section. I'm Ian Wheatley. I'm a nursing consultant at Frimley Health, and I'm going to talk about managing rhinitis in people with obstructive sleep apnea hypopnea syndrome, which covers off the same thing in obesity hyperventilation syndrome and COPD overlap syndrome. So, patients with OSAHS suffer from nasal congestion at times. Patients tend to have rhinitis in 2 sort of main groups, whether that's allergy related or non-allergy related rhinitis. Treatment is similar in both. Non-allergy is generally less itching and less irritation, but obviously treatment is still similar. Committee discussed managing rhinitis in people with OSAHS, and there was a lack of sufficient evidence in regards to the management of these patients. So it's generally based on collective experience and knowledge of current practice. So we know that nasal obstruction congestion impacts on sleep disordered breathing, leads to mouth breathing, worsens mandibular and base of tongue retraction, and exacerbates obstructions. So general and real practical measures, really. So allergic rhinitis, avoid the allergens. You may want to treat the patient with nasal steroids, nasal irrigation, decongestants. Patients with allergic rhinitis, antihistamines, maybe leukotriene receptors, agonists in concomitant asthma, or a combination of the treatment options indicated. So generally practical steps in rhinitis. Other aspects considered were things like moving your patient from a nasal mask to an oral facial mask, adding in humidification, as Adrian mentioned about humidification earlier. We don't generally add in humidification as a first line. Some centres might do, but it is an option as an option for a patient. Try targeted nasal spray, and then if still you're finding problems and not controlling the patient's rhinitis problems, then for an ENT review. So the patient may have some sort of anatomical obstruction or another issue that needs to be treated. Next slide. So the guidance and on the NICE website has these lovely flow charts, which will take you through all treatment options. And just for rhinitis, most of the slide set will have a section for rhinitis in it because it covers off all the other areas. Next slide, please. So generally there will be a box on the flow chart that says to assess people with nasal congestion and treat, with the suggestions as mentioned, whether that's with the sort of steroids or humidification, changing the mask, etc. Next slide, please. So it's going to bring you on to talking about telemonitoring and monitoring patients in general. Over the last year, we've come a long way in how we review patient data and manage patients individually. And I think we've, if we'd been where we are now when we started with the committee and looking at the guidelines, then we may have been in a different position. But research is limited. There was evidence of about 10 studies, and 6 studies had telemonitoring and one person and an in-person follow-up. One of the studies was telemonitoring and telephone follow-up, a study with multimodal telemonitoring against usual care, and 2 studies, telemonitoring and televisits with in-person follow-up. All the studies, bar one, were with fixed level CPAP. And we know that traditionally fixed CPAP has been in practice for a long period of time. So there wasn't so many with the auto CPAPs, which may have changed things. And potentially this is an area of research going forward that would be really useful to determine telemonitoring fixed level auto sets and things like duration of telemonitoring. So the studies themselves were all on a severe population. Where there was a mixed population, the severity used was by the mean of the AHI. And the follow-up range was between 2 and 12 months, and sample sizes vary between 45 to 306 patients. The data is very inconsistent across the studies, but there was evidence that adherence improved with telemonitoring, which is a good point. If we can review data by remote, we can see what's happening, we can titrate and change pressures and things for patients, and we can do that without patients having to come to see us, and that's been evident throughout the last year or so. So there's advantages in telemonitoring. You can look at night-by-night data, and you can do remote CPAP titration. In practice, there are centres that do lots of different things. Some centres repeat sleep studies. You download device data. Some may do blood gases and overnight CO2. The data does show that it's best to review patients early, and the committee considered 1 month as an early step, and then individualised, and telemonitoring allows this, and some centres may do sooner sort of reviews of patient data. So next slide, please. So monitoring treatment efficacy of CPAP and also other devices. So the committee looked at mandibular advancement splints and positional modifiers, and obviously they're far more challenging to get information from, because currently there's very limited devices that you can retrieve information from, although they are coming. So we think that you should do telemonitoring for at least the first 12 months of treatment.
Sorry, it's my fault. I've clicked the wrong button. I knew there'd be a technical hitch. Sorry, everybody.
So
quick
I'll
stretch.
carry on. Mandibular advancement splints, more difficult to assess adherence to. You could repeat a sleep study. I think what was more of a challenge with mandibular advancement splints are places that actually make them so that you can utilise that type of device. But maybe in the future, these devices will come with some sort of compliance information built in. Position monitors, again, it's the same sort of thing. You may want to repeat a sleep study to determine the effectiveness of this treatment option. And what do you want to assess? Well, committee discussed things like symptoms, efficacy of treatment, the impact of comorbidities, the patient's adherence to treatment, which is obviously quite difficult when quite a lot of the devices, apart from the CPAP therapy, do not have a monitoring capability. What else with these items? Well, you need to tailor your patient treatment plans. So you need to look at things like lifestyle changes for the patient, sleep hygiene, weight management, any sort of modifying sedative drugs, alcohol, stopping smoking, treating the patient's lung disease and other comorbidities. The committee discussion felt that early review was really important. Hopefully in the first month, if you can do it. I know some centres are really stretched and 3 months is the earliest you can do it. You can discuss the care with the patient, the issues, you titrate their therapy, any further testing that the patient requires, and answering their clinical questions, because if you do that early, then hopefully you can improve adherence really early and that'll be sustained. And then you can tailor some subsequent reviews to patient needs. So if your patient's really compliant and they're really adherent to the treatment, then you may want to stretch out their review periods, and others may need a bit more input, and you can tailor that accordingly. The committee felt that you need to optimize the AHI or the ODI, optimize adherence early, and early assessment helps with problem solving, and telemonitoring for at least the first 12 months, beyond if control is not achieved, and sometimes beyond may be useful if you're trying to reduce footfall in your clinics, as we've seen over the last year or so. And patients should be reviewed at least yearly. Next slide. Thank you. So, like I said about the flow charts, within the flow charts, you'll have a guidance box which will explain things like monitoring and support. Next slide, please. And I'm going to hand over to Chris.
Good morning, everybody. I was diagnosed in 2001 with severe OSA and excessive sleepiness, and I've been on CPAP for 20 years. I've also been involved directly with the CPAP, with the SATA support charity, patient support charity, for 10 years. My role and another lay colleague was to bring the patient's perspective to the fore in the guideline meetings. I have to congratulate both NHS and NICE first in recognising the need of a new guideline for this chronic disease and then achieving it. The UK now has what would appear to be the world's first up-to-date clinician and patient's manual on the referral, diagnosis and treatment, not only of OSAHS, but also AHS and COPD OSAHS overlap syndrome. The presentation of the guideline on the NICE website is simple and effective. The referral, diagnosis and treatment pathway diagrams are outstanding in their clarity and provide a very understandable representation to patients and what may happen to them. What is more, it's also fit for the post-COVID medical environment, recognizing the role that newly developed technologies can play in reducing risk. This first slide illustrates in detail what needs to be done in terms of communication and is perfectly outlined in section 4.1 of the new guideline, but I'll deal with this later. Can I have the next slide, please? So did patients get what they wanted? And does the new guideline meet their requirements? Without going into detail, I think it's best to outline what the two patient charities, the Sleep Apnea Trust and Hope to Sleep, requested in their comments to the initial stakeholder draft of 2018, and whether the new guideline has delivered. Their consultation comments were based largely on helpline and forum feedback from patients. We're talking about thousands here, particularly those newly diagnosed. In point 1, we wanted mandatory CPAP treatment for those diagnosed with symptomatic mild OSA. We got it, and there was a bonus too. It has been incorporated into an updated NICE TA 139, which, with its legally mandated funding requirement, will eliminate the wide variation in treatment decisions for such patients between sleep clinics in England. With point 2, we recognise that 1/3 of patients who start CPAP therapy stop using it in the first year of treatment. Customised and semi-customised mandibular advancement splints will now be considered to help these patients and others who may have an aversion to the idea of CPAP. We're happy with this. Point 3 concerns positional sleeping problems, and they have been addressed in the guideline, which we welcome. Point 4, humidification has had to be offered as an intervention where needed and about time. On point 5, where patients whose jobs involves risk to others, for example, lorry and bus drivers, has already been mentioned, they will now be prioritised, and this is welcomed after years of campaigning by the OSA Alliance. In point 6, and this is a little bit more complex, the 4-hour compliance confusion is addressed, which has never been an official rule in the UK. Make that clear, never been a rule. It was a mistaken transposition of the USA health insurance regulations, which state that in order to justify the expensive CPAP therapy, a minimum of 4 hours use per night for 70% of nights is required, or 2.8 hours every night. Somehow in the UK, it transmorphed into 4 hours per night for every night and has caused more stress for drivers in particular than one can imagine. On page 70 of the guideline, in the section supporting adherence to treatment of OSAHS, hours of use has been clarified into a qualified clinical guidance based on common sense and medical expertise. Finally, in point 7, which addressed lifestyle advice, the guideline advises it at a level not previously considered, and this now has to be addressed. So based on what patients have told us, these points will be delivered. On next to what was requested and not exactly delivered. Auto CPAP or manual CPAP is a significant issue with patients and also the Association of Respiratory Nurse Specialists. There is now clear guidance. The default is manual CPAP with telemonitoring, with though a recommendation for more research has been outlined. Auto is listed, but is only available if at the same cost as manual. We would have preferred to have seen the default as auto with manual available if clinically preferable. A manual machine would need to have the pressure altered by a skilled clinician, either remotely or in person. Helpline feedback tells us that next to mask problems, pressure adjustments are a major inconvenience. Patients cannot understand why they are not provided with auto, especially when newly diagnosed and an auto machine was used to titrate their pressure. It is then replaced by a manual. It would seem that efficiency alone would be more than cover any price differences, as Adrian pointed out, which may seem to be quite small now. I will now address what patients see as probably the most difficult recommendations in the guideline for the new COVID world, and those are the communications challenges. The first challenge is the development of local support groups to encourage adherence. SATA was established at the Churchill Hospital in Oxford in 1993 to do exactly that, for patients to meet locally, discuss experience and exchange ideas. With rapid growth, it became a national charity in '96 and continues to grow. Many other groups were formed and were successful for a long time, but most have failed. The big ones, such as Humberside, Leeds and Bristol, have gone. Smaller groups like Swindon, Yeovil, Wigan and Lee thrive and prosper. Now, why is this? Our experience is that the local NHS staff are the key to success, and it is they that drive the group. It often means evening and weekend voluntary work that enables them to thrive. We encourage local groups, but there is a lot of work to be done to make them viable on a national scale and to engage support from the local sleep clinic staff. The second, and by far the most challenging, is information communication to patients about their illness, its diagnosis and treatment. There's very, very much work to be done here. As I already stated, section 4.1 of the guideline lists communications opportunities in many areas that only the best sleep clinics do routinely. And as we well know, sleep clinic performance varies widely in the UK. The reorganisation of the NHS into 42 integrated care systems may overcome the fragmentation of communications that has inevitably thwarted progress in this field. Part of the role of our charity is overcoming this fragmentation and has been to develop a comprehensive range of leaflets for patients supplied directly to sleep clinics and free of charge. Sadly, less than half the sleep clinics use this free resource. That said, the advice on the SATA website about driving and the DVLA is recognised by all as the best reference source in the UK and is downloaded by many more sleep clinics and given to patients. Most of the helpline requests to SATA deal with driving. And despite our information and excellent BTS guidance, the DVLA forms are out of date and the online system causes many problems due to the confusion of the patient not knowing whether they have obstructive sleep apnea or obstructive sleep apnea syndrome. Unfortunately, I always get angry about that one, but there we go. Unfortunately, the words primary care are absent from the guidance, and its role really needs to be better defined by the NHS to make sure. GPs must be targeted directly with up-to-date information on what NICE has achieved and as quickly as possible. We are already using sections of text from NG 202 to advise helpline contacts, and they are going back to their GPs and saying, in the new guideline, it states this. So what the new guideline precisely identifies by listing what needs to be done is a communications vacuum. That is, at present, only filled by 2 charities. Taking this to another level, communication has to be led from the top. So I must draw attention to the enigma of the NHS website. If you Google sleep apnea NHS, you get an NHS website page with information that was last updated on the 7th of August 2019 and will not be updated until the 7th of August 2022. It is hopelessly out of date. The NHS at board level needs to get its communications integrated and must, at the earliest opportunity, update the sleep apnea information to take into account this great new NICE guideline. In closing, despite the challenges and problems I've outlined, my overall feeling is very optimistic. So to answer the question I originally posed, I think patients have got what they wanted, and the new guideline not only meets, but exceeds their requirements and expectations. Thank you for your attention.
Thanks, Chris, for really representing the patient's view well and drawing that final slide in that session to a close. I'm just going to invite all our panel to put their screens on, and then Ian Stone is going to be coordinating us for discussion. We're probably going to bring this time slightly forward, so don't anyone run away till we've just to get coffee till we've reset the time according to how much discussion we have. Ian, over to you.
Great. Well, thank you very much, everyone, for your talks. You've covered a lot of information in a relatively short period of time, which is always a challenge in these half-day sessions. And there are loads of questions coming in, actually. I think the obvious place to start is around compliance with therapy. There's a few questions around what is considered good compliance with CPAP therapy. Is it 4 hours? Is it 70%? What are people's views? So Anna, there's a question directed directly at you in relation to your comment around 4 hours. So what are your views?
So thank you very much to whoever posed this question and pulled me up on it. You're quite right. When I presented the merge data, I said, 4 hours was excellent. And of course, what we're all passionate about is a patient-related outcome measure after a trial of CPAP. We're really interested in the patient feeling that their sleep quality is better, their vitality, sleepiness, and energy is better. And Chris has very importantly articulated that there is nothing magic about 4 hours. I think we have to acknowledge that many of our patients gain excellent benefit using it for less than 4 hours. So it is very arbitrary. We tend to give them a lot of encouragement in that first month. Use it as much as you can, all night, every night, acknowledging that some people will use it less than that. I think you have to work really hard closely with the patient within that first month to troubleshoot any problems such as mask fit and humidity. And then I think we have to acknowledge at the end of a really good trial, when all the tricks in the book have been used, that for some patients it isn't the best way forward. And then we truly need to say, did we get the diagnosis right? Do they have symptomatic obstructive sleep apnea? Or is it another factor disrupting their sleep? Or do they need to go down an alternative strategy, such as a mandibular advancement device and enhanced support with weight loss?
Great, thank you very much. There's other questions coming in, just really comments really around the discussion around auto CPAP versus fixed CPAP. I think as a panel, as a committee, we had quite heated discussions about this. I think they're continuing in the chat on the side. I think there are lots of different experiences, and people held quite strongly in the chat also hold strong views in relation to this. It's interesting though, with the Philips recall, that a few centres look like they've had to switch from auto to CPAP. So it's real life data on the differences between auto and fixed CPAP. And Ian, you've commented in the chat actually on your experiences, and I think Katrin also in the chat has also commented on her experiences, and they're quite different. So I think, you know, the data showed that there weren't much differences between auto and CPAP in relation to the main outcomes we look at, and I think that's borne out in the discussions. It is really around the management of your services where the challenges lie in auto versus CPAP. Do you have any comments to add, really?
I think you're correct, Ian. But you know, largely it was around what centres were doing and how they were doing it. So, which, you know, for us, we use a lot of telemonitoring, a lot of APAP for a long time. So that's much easier for us. And there's some interesting chat in the chat box. So, going back to the how long should patients be on CPAP for? Chris Rogers always has a good take on what his patients experience. I don't know if Chris, you want to mention about the 4 hour side of things.
I missed that. You were slightly distorted.
Sorry, yeah. So, you know, we have lots of discussions about compliance and adherence on CPAP therapy and what should be the length of time for patients. And you often, during our committee talks, mentioned about patients, how they felt and how long they needed to be on it. Was more important than an arbitrary a time, an exact time.
Yeah, it's very much going back. Let's do the driving one first. The law in this country is very clear. It's up to the driver. At the moment they put the key in the ignition, they are responsible, and they have to assess whether they are fit to drive or not. And if they become tired, they're supposed to stop and rest. When I was diagnosed, and I was a professional driver by training, test driving of very fast cars, I sat at Oxford and was told I couldn't drive home because I had a network score of 18. So the way it affects you can be so considerable. The amount of time needed is in the end, I guess, a relationship between the sleep clinic and the patient. The patient has to understand that it is entirely their responsibility. Driving tired is not acceptable. For me, I got the benefit of CPAP within 1 week. It was astonishing, and I've 20 years now of brilliant sleep. Although one has to say that at 74, I used to get away with about 4.5 hours a night, and I'm now up to about 6 hours a night. But there we are. That's age related and already very well documented. The 4 hours argument is sadly used by some sleep clinics as a pressure item. I think the wording that's used in the guideline is really superb. From a health point of view, you need to be on a CPAP as long as possible. And from a driving point of view, you have to be completely sure that you're going to be safe to drive. So having these arbitrary rules, which emanate from the USA, it's very much up to the individual experience. It is the most personalized of treatments that a patient will have. There's nothing like it. A mask on your face when you're sleeping. So.
Great, thank you for that, Liz. There's a few questions around the impact of auto CPAP on comorbidities, really, the treatment and the effect on comorbidities. There's a few talking about there's pressure settings and the impact on central apneas, potentially. Something interestingly, I had an email correspondence with Ian about just this week. So, so I think that might be something, it's kind of out of the scope of the guideline, to be honest, considering central apneas. It's not, this was mainly obstructive sleep apnea and hypopnea guideline. But what's your view on the risk of sort of pressure settings and central apneas, and whether or not we should be thinking about changing the settings on the device to try and accommodate that? Ian, what you told me last week in the email, did you?
Yeah, I mean, for us, we'd look at if we're using APAP, then we'd look at the APAP data much more closely and determine whether we need to tighten up the pressure settings. And that may be like the other colleagues on the chat are talking about going to fixed pressure. But generally, we would alter the pressures to see if, because some of the APAP machines have got a feature in there which will not increase pressure to overcome obstructions if there's central apnea appearing. So there are various devices out there that do various things. And then we'd consider other factors and whether we need to do an echo and put the patient onto a different device. And Anita, I think you commented on the same email from Ian.
Yeah, I did. And I think the heart failure patients are somewhat different, and there are lots of considerations there, including the ejection fraction, the percentage of central sleep apneas, and also whether the central component is treatment emergent, in which case the predominant problem is obstructive sleep apnea. You uncover a central element, but that may improve over time. So it is out with the scope. Could I briefly add a couple of other comments on the other issues, but I'll be very, very brief indeed. On the adherence issue, yes, exactly. We took really keen notice of what Chris said and what Anne, our other patient representative, said, and you'll see in the discussions at the end, we said there is evidence actually for 4 hours use. Terry Weaver did a study and showed improvement in measures of sleepiness after 4 hours, but that has then got translated and kind of built into a kind of commandment of what it should be. So absolutely agree with Chris. And we understand too that this is a very variable condition, and for example, there is evidence that you need more than that period of time, 5 hours or more, to improve some of the cardiac consequences such as hypertension. So this is a really active area, but you work with the individual exactly as we've said, and so you shouldn't be hard and fast about it, but usually the more use the better, and particularly in REM sleep as well. The second last point to make on the auto CPAP and the fixed CPAP is, as nice process, we had to consider the trials. The comparative trials between auto CPAP and fixed level didn't include the whole management process of the patient, but did show equal efficacy. So the argument that the auto CPAP is better didn't come out from the styles or equal efficacy, but the health economic analysis, because by and large NHS costs show the fixed level are cheaper, came out in the favor, as we have discussed, but we've added lots of caveats to be pragmatic, just as we did for the oximetry question. The other thing to say is that none of those comparative studies included telemonitoring, such in the first few nights with fixed level, you can adjust the pressure remotely. So there's lots of developments that weren't included in those randomized trials, which is why we've been pragmatic. Thanks.
Adrian, do you have your hand up? It looks like you do.
Yeah, I just wanted to add a couple of things from some of the comments. We've managed to work our way through the current national crisis of a lack of CPAP from one supplier, and we are actually continuing to use auto CPAP from various sources, not necessarily on the NHS framework. I think the one thing that it does highlight, though, is that the algorithms that are being used both for fixed pressure and, importantly, for auto CPAP are not the same. And they may not give you the same information. So if you've switched a patient from device A to device B, different suppliers, you will end up not necessarily getting the same data in the same level of understanding because of the way the software and the algorithms actually work. And that's a real problem currently because of the crisis within the provision of CPAP machines in the UK.
Thank you very much. There's one question around the fact that we've not really spoken about asymptomatic, moderate and severe sleep apnea. I think that was covered in the TA from a number of years ago. So we would consider treating all of those patients with CPAP as first line, regardless of their symptoms, just to be clear about that, and the guideline supports that. There was a more recent question around comorbidities and the impact of the 4-hour usage on long-term outcomes. And this is actually, there is more recent studies that actually suggest you need slightly longer than 4 hours for some of the cardiovascular outcomes, for blood pressure control. I think more recent papers have suggested 6 hours use actually is better than 4-hour use. So I guess it would depend on your patient in front of you, depending what exact recommendation you may make for them. I don't know if anyone else has any other comments in relation to that. The specific question was long-term health issues as well as sleepiness, and should we be using it less than 4? Does it make a difference? That was a question. I don't know if anyone else has a comment about that.
Can I just make a comment there? And
yeah, sure.
If you're going to specify a recommendation time, you know, when you're dealing with patients, they'll say, well, if I have it for 12 hours, then I'm going to be, you know, perfect. So we need to understand that the recommendation is people should sleep to a maximum of, is it 9 hours? In terms of health, maintenance of normal health?
8 hours, I think, is recommended.
8 hours, right.
Yeah.
Okay, so I think that's important to stress as well. If you're going to recommend a minimum or a suggested or a good level up to a maximum or a certain time, because we are dealing with patients who need to be guided on something like this.
Sure, absolutely. There was another question just come in to ask some more about, sorry, Sophie, your hand is up.
Sorry, always thinking ahead to the coffee. Could we have just a couple more questions, Ian, and then 5 minutes and start the next session at 11:30?
Absolutely.
Thanks,
let me just dig some out. Is there any other? There's quite a lot on compliance, but I'm just gonna I've done that. There's just comments on how to set up people on fixed pressure, and I think something that's come up in the chat is, and what's used in Oxford, perhaps unsurprisingly, is a straddling equation. It's typically used for recommending fixed pressures for those centres that use fixed CPAP. A number of them have come up in the chat. I think that's just something worth mentioning. And more recently, there was a question. Anita's typing an answer. Do you want to say your answer, Anita, for that last question in relation to 1 hour compliance?
It'd be a lot quicker.
Yeah,
I think less than 1 hour is unlikely to be enough. I mean, mostly obstructive sleep apnea is more severe. Hyperventilation in obesity hyperventilation is worse during REM sleep. You're unlikely to have hit your first cycle of REM sleep. I don't know which hour in the night they've decided to use, but there is a discussion, whether it's 1 hour or not, around when you stop in the night, and you tend to have more REM sleep when your sleep disordered breathing is probably worse in the second half of the night. So people who just use it for the first 3 hours and then leave it off may be undoing some of the good that they might do in the second half of the night. So the short answer is less than 1 hour a night is not enough.
Ian, there's another question I wonder if Annabelle wants to take from William Sims. What about the cohort of patients who deny any symptoms of clinical significance but have moderate or severe OSA, and the only reason they are there is snoring or witnessed apnea? Annabelle,
that's an excellent question, and Sonia Craig and John Stradling in Oxford addressed this through the Mosaic study. with patients who were minimally symptomatic and did demonstrate benefit of symptoms in this patient group. So I still encourage my patient to give it a go. I say to them, well, look, your symptoms your sleep apnea will have come on insidiously over many years. We normalize these symptoms. There's a reasonable chance you have a good energy boost. So I get them to give it a go. In the days when we always used to be face to face, I used to look at the eyes of the spouse when discussing driving and really thinking, how symptomatic are they? Because the spouse's eyes sometimes tell you a different story from the words that are used. I really regret that with our phone conversations. I think we miss lots of nuance. And we must acknowledge at the end of the day, we will have some patients with moderate or severe sleep apnea who you twist their arm, they use it every night for 2-4 weeks, and they come back and they say, it's an awful pain, I have no benefit, I'm not sleepy driving. We screen them for symptoms relating to driving, accidents, near misses, alerting mechanisms. And then we have to acknowledge they're truly not symptomatic, and it is their responsibility to not drive when sleepy. We let them go without treatment, but say that the door is open if they develop symptoms in due course.